Welcome to our lecture on antimicrobial stewardship in dispensing, and today we will explore the critical role of healthcare professionals in optimizing antimicrobial use within a dispensing practice. Antimicrobial stewardship is a vital component of modern healthcare, and it is ultimately aimed at ensuring the rational use of antibiotics. We will be exploring the principles of antimicrobial stewardship and its significance within the healthcare sector. Topics that we will be covering includes an overview of the current antimicrobial stewardship landscape, potential strategies of including antimicrobial stewardship within the dispensing practice, and then together we will be looking at potential ways in which we can move antimicrobial stewardship forward. So what is the current landscape of antimicrobial resistance? Globally, it is currently the most silent pandemic of antimicrobial resistance, and it is increasingly claiming the lives of patients on hospital floors and in community practices. Thus, we are now gradually and progressively facing the silent emerging pandemic that could endanger some of the most significant advances in healthcare. In a recent study, it was estimated that 4.9 million deaths may be associated with bacterial AMR in 2019. This includes 1.27 million deaths attributable to bacterial AMR. At a regional level, the all-age death rate that is attributable to resistance is the highest in Western Sub-Saharan Africa at 27.3 deaths per 100,000. Lower respiratory tract infections, which is commonly treated in the community practice, accounts for more than 1.5 million deaths associated with resistance in 2019, making it the most burdensome infectious syndrome. The 6 leading pathogens for deaths associated with resistance is Escherichia coli, followed by Staphylococcus aureus, Klebsiella pneumoniae, Streptococcus pneumoniae, Acinetobacter baumannii, and Pseudomonas aeruginosa. In a study published by Nature, it illustrates how these 6 pathogens are responsible for more than 3/4 of those deaths, and a global survey found varying levels of antibiotic resistance depending on the pathogen and the antibiotic. High levels of antibiotic resistance were seen for Acinetobacter baumannii, for which 73% of the isolates were resistant to carbapenems and 56% resistant to aminoglycosides. Neisseria gonorrhea, for which 60% of the isolates were resistant to ciprofloxacin, and Klebsiella pneumoniae, for which 57% of the isolates were resistant to 4th-generation cephalosporins. So, what is antibiotic stewardship, and does it really have anything to do with dispensing practices? In fact, it does. Antibiotic stewardship is an ethical value that embodies the responsible planning and management of scarce resources, using a systematic approach to improve the use of antimicrobial drugs in order to optimize patient outcome, minimize adverse events, and prevent the emergence of antimicrobial resistance. It involves a range of activities and strategies, and it requires coordinated interventions that is designed to promote the appropriate use of antibiotics. These interventions, as illustrated on this slide, is what we will be investigating as part of this lecture. When we look back at our definition, antibiotic stewardship involves infection control, which is often called the orphan child of stewardship. And with infection control, it requires careful antimicrobial management, appropriate antimicrobial selection, the right dose, which is to be administered at the right route and for the right duration. It also involves the selection of antimicrobials that causes the least collateral damage. Our primary goal is always to optimize clinical outcomes and to minimize the unintended consequences of antimicrobial use. Unintended consequences may involve toxicity, selection of more pathogenic organisms, and the emergence of resistant pathogens. The secondary goal involves improving patient safety and reducing healthcare costs without adversely impacting the quality of care. All of this should be evidence-based. So antimicrobial stewardship rests upon carefully ethical principle that should be navigated, and this navigation requires always looking at the patient's safety versus the efficacious use of antimicrobials. Not using antimicrobials might keep a patient even more safe than using an antimicrobial irrationally. Within the dispensing cycle, there's different phases, as you will be learning throughout this course. Within the first phase, it involves interpreting and evaluating the prescription. In this phase, antimicrobial principles could involve evaluating the appropriateness or even the need of an antimicrobial. Verify the indication, evaluating the dose and the duration of therapy, checking for potential drug-drug interactions and contraindications, and evaluating the need for a dose adjustment within a specific disease condition, and then including patient factors so that we have personalized delivery of healthcare. This may include renal function and weight. Considering alternative practices or treatments if prescribing therapy is not needed. For example, delayed prescribing. We will also be looking at that later on in this lecture. Phase 2, preparing and labeling of the prescribed medication. IMS principles in this phase involves ensuring accurate selection of the prescribed antimicrobial, preparing the correct dose and formulation, especially in pediatrics, labeling the medication with clear instructions for use, including the duration of therapy. This also involves health literacy. Are you sure that your patient will be able to understand what is written on the label? Including relevant warnings or precautions on the label, and considering alternative labels to reinforce proper antimicrobial use. Phase 3, provision of information and instructions to the patient. This is a very important phase and involves carefully making sure that your patient will be able to understand the level at which the message is delivered. In this phase, we have to involve education on the importance of adherence to antimicrobials and to the prescribed regimen. Provide clear instructions on how to use the antimicrobial. Explain specific adverse events that may occur and when to seek medical attention if they do not respond to the therapy prescribed. Emphasize the importance of completing the therapy if needed and discussing proper storage and disposal of unused antimicrobials. By incorporating antimicrobial stewardship principles in each of these phases, a healthcare worker can play a crucial role in promoting the appropriate use of antimicrobials whilst dispensing medication. Currently, it may be time for a paradigm shift in the management of serious gram-negative bacterial infections. A paradigm shift is needed to provide appropriate and effective initial therapy of antimicrobials, preserving both old and new antibiotics. New antibiotics that are on the market, maybe not so new anymore, include ceftazidime, avibactam, ceftolozane, and tazobactam, offers valuable options for resistant gram-negative bacterial infections. I'm using these two drugs, although not prescribed at a community level, to explore the principles of a paradigm shift in the face of the current antimicrobial resistant pandemic that we are facing. It involves a more nuanced strategy required. We may need rapid diagnostics, and we are going to look at diagnostic stewardship to guide targeted therapy, reserving new agents for confirmed resistant infections, de-escalating to narrower spectrum antibiotics if needed, optimizing the use of existing antibiotics through proper dosing. This approach can provide effective treatment while preserving antibiotic effectiveness long term. By shifting to a more targeted, evidence-based approach, we can optimize patient care while promoting responsible antibiotic use and stewardship, even at a community healthcare level. Translating microbial data relating to beta-lactamase genealogy in South Africa into clinical practice and enablement of this information at bedside remains a formidable challenge. Beta-lactamases such as OXA48 and its variants and New Delhi 1 either alone or simultaneously present on plasmids and are predominantly carbapenemases amongst Enterobacterales with very few or no Klebsiella pneumoniae carbapenemases or other carbapenemases evident. Reasons for misuse in an outpatient setting. In a recent study conducted in 2020 to evaluate antimicrobial stewardship in community healthcare settings, interviews were held with the different members of the multidisciplinary team. Some of the factors mentioned by clinicians were commercial factors. Commercial factors that were mentioned included that clinical pharmacists felt that medical representatives, while introducing a new antibiotic to a doctor, might not have explained its full spectrum. This will invariably lead to doctors writing another antibiotic unknowingly, leading to double coverage. Some of them said, for example, suppose doctors are writing an antibiotic suggested by a representative, and suppose it has gotten anaerobic coverage. It might not have been checked. Emphasizing again the importance of the dispensing process to make sure what is prescribed is really needed. Comments from the doctors included that many doctors felt justified in antibiotic use by quoting clinical signs and symptoms in the patient, saying, "You educate the patient to come back if they have purulent sputum. They come back telling that they have purulent sputum in the morning. The sample may appear to be clear at the time of examination, but this clue seems to be enough for doctors to prescribe antibiotics." How ethical is the use of antimicrobials when it's not needed? We can look at the principle of utilitarianism. Utilitarianism is a consequentialist theory that determines morality that is based on the outcome of an intervention. When we ask ourselves the question, is there an ethical responsibility to consistently provide good patient care? The principle of utility asserts that the moral course that one has to take should be to maximize value over disvalue and seeks to be at the greater benefit for the greatest number. Within antimicrobial use, this leaves us by saying that sometimes not prescribing antibiotic is for the greater good of humankind. Utilitarianism in the context of AMS and vaccination focuses on maximizing the overall benefit and minimizing the harm for the greatest number of people. When it comes to dispensing vaccines as part of AMS efforts, a utilitarian approach would consider the following principles: individual safety and utilitarianism safety, so the patient safety and the community safety. This feeds well within the antimicrobial framework that is set out by the National Department of Health. Within the antimicrobial stewardship framework, you will see it includes enhanced surveillance, antimicrobial stewardship, IPC, and vaccination that is laid on the foundation of education and feeds into governance and ultimately feeds into a larger framework of governance. Opportunities for antimicrobial stewardship at a primary healthcare level. Community healthcare providers remain the most accessible healthcare providers, and with most of the antimicrobials being dispensed at a community healthcare level, this provides a unique position for healthcare providers to contribute to the management of antimicrobials. Some of these strategies may include education, antimicrobial treatment optimization, communication with other healthcare team members, and including the conscientious dispensing of antimicrobials. The current AMS landscape within the community of South Africa had some interesting findings. This study that was published in 2016 by Adrian Brink had the following key points. 75 to 80% of antibiotics prescriptions are in the outpatient setting. Some of the most common indications included upper respiratory tract infections, true for both adults and for pediatric patients. 50% of the antibiotics investigated within the study was found to be inappropriate. The problem was that the majority of upper respiratory tract infections remain viral. Thus, antibiotics are completely ineffective. Yet, antibiotics were prescribed for just in case, and this may lead to adverse events for patients like Clostridium difficile, increased healthcare costs, and development of resistant bacteria. Target areas for improvement included educating patients on the appropriate use of antibiotics or not giving them antibiotics at all, implementing antimicrobial stewardship programs within the community setting, developing rapid diagnostic tests to be used at a community setting, and setting prescribing targets and monitoring adherence of antimicrobials. One of these interventions include delayed prescribing. Furthermore, antimicrobial stewardship within the community setting also involves health literacy. There are several misconceptions and linguistic barriers that have been identified amongst the minibus taxi community when it comes to understanding terms like antimicrobial resistance or antibiotic use, or just antibiotics in general. In this study, language and use of antimicrobials were investigated within taxi drivers and other commuters within the Gauteng province. Important findings included that there should be raised awareness to find terminology amongst all languages spoken in South Africa that can be easily understood within the community. Healthcare providers may consider the cultural and linguistic context of minibus taxi communities and their patients in general, and use defined and appropriate indigenous terms when they are educating their patients. As you can see on this table, in many of the local languages, there simply aren't any words to express antibiotics or to explain how antibiotics should be used. Which antibiotics are used within the community healthcare setting? In this paper, they evaluated antimicrobial consumption in the public sector in 18 community healthcare clinics, and 21.5% of every patient, that's 1 in every 5 patients that visited the community, received 1 or more antimicrobial, mostly amoxicillin, isoniazid, used for TB prophylaxis. The majority of these antibiotics were from the access group, and again, it illustrated that the majority of antibiotics were prescribed for upper respiratory tract infections. What about using antibiotics over the counter? In this study, mystery shoppers have been used to determine the practices pertaining to antibiotic dispensing without a prescription amongst community pharmacies within South Africa. The use of these mystery shoppers allowed researchers to assess the accessibility of antibiotics without a prescription and whether counseling is provided when antibiotics are dispensed. 2 case scenarios were used: upper respiratory tract infections and urinary tract infections. The findings were interesting to say the least. The findings illustrated that privately owned pharmacies in urban areas commonly dispensed antibiotics without a prescription. In 80% of cases, antibiotics were sold without a prescription in privately owned pharmacies, while no antibiotics were dispensed in corporate or franchised pharmacies. The most common antibiotics that were dispensed were ciprofloxacin and metronidazole for urinary tract infections. It was also observed that pharmacist assistants were involved in the dispensing process in the majority of cases, and counseling was not provided to a large portion of these cases. So what can we do about this, and what is your role as a dispensing practitioner? Let's look at some of the studies that was done. In this study, they evaluated the effect of behavioral intervention on inappropriate antibiotic prescribing amongst primary care practices, a randomized clinical trial. It involved 47 primary care practices, and 3 behavioral interventions were used. First, suggested alternatives, accountable justification, and peer comparison. Practices were randomized to 0, 1, 2, or 3 of the interventions. They evaluated antibiotic prescribing rates for common cold, influenza, and bronchitis. What did they find? In these 3 behavioral interventions, implemented either alone or in combination based on the randomization, the suggested alternatives presented electronic order sets suggesting non-antibiotic treatments. Accountable justification prompted clinicians to enter free text justification for prescribing antibiotics into patients' electronic healthcare charts. And peer comparisons were used to send emails to clinicians comparing their antibiotic prescribing rates with those of other top performers, if you want to put it like that, those with the lowest inappropriate prescribing rates. In other words, clinicians were asked to evaluate themselves and their colleagues. So when we look at these practices and interventions, within the control practices, they decreased from 24 to 13%. Suggested alternatives decreased from 22 to 6.1%. Accountable justification decreased from 23 to 5.2%. And peer comparison decreased from 19 to 3.7%. So the key interventions that has driven these changes were the suggested alternatives, suggested or encouraged the use of alternative treatments. Accountable justifications required clinicians to justify each of their antibiotic prescription, leading to a significant reduction in inappropriate prescribing. Peer comparison provided feedback on the prescribing rates compared to their peers, promoting evidence-based practices. Overall insights in this study allowed us to see that all interventions involved a modest change to the practice environment. It involved a nudge. None restricted the clinician's treatment choices or altered payment structures. Peer comparisons is practical but depends on valid performance measures. And accountable justification requires an electronic healthcare record but is broadly applicable. So what happens if all of the interventions were stopped? So later, after 12 months after removing all of these behavioral interventions of this study, they re-evaluated these practices. They looked at the inappropriate antibiotic prescribing for upper respiratory tract infections, and they saw that it again increased as compared to control practices, whose inappropriate prescribing rates continued to increase. However, there was still a statistically significant difference between peer comparison and control practices 12 months after the intervention were removed, possibly because this intervention involved delayed prescribing. Delayed antibiotic prescribing has emerged as a valuable, practical strategy in antimicrobial stewardship, as it offers a balanced approach to antibiotic use that benefits both patients and healthcare systems. This approach involves providing patients with an antibiotic prescription whilst advising them to wait before they fill it, typically if symptoms worsen or do not improve at all. Studies have shown that delayed prescribing can significantly reduce unnecessary antibiotic use, specifically for upper respiratory tract infections, whilst maintaining patient satisfaction. If we look at communication strategies, this is an interesting study that involved reducing inappropriate outpatient antibiotic prescribing, a normative comparison using unblinded provider reports. The participants were ambulatory primary care providers in large regional healthcare systems. The test group involved 30 primary care providers in one geographic region. There was a control group with 162 primary care providers located in 4 other geographic regions, physicians and advanced practice providers. Each region had 20 to 40 participants in regular contact with intra-regional participants. It involved a non-randomized controlled interventional trial over 1 year, followed by an open intervention in the second year. Which communication strategies were involved? The communication strategies that eventually led to the best outcome involved communicating the following to patients, giving them a specific diagnosis. So, for example, if delayed prescribing is involved, or if no prescription is going to be given to the patient, they suggest the following. Give the patient a specific diagnosis. For example, say, you have a viral infection, or you have viral bronchitis. Provide symptomatic relief. For example, the CDC has a wonderful prescription chart that lists each symptom with an alternative therapy that can be given. Share normal findings as you go through the exam. Don't just list the abnormal findings. Discuss side effects of antibiotic use. For example, say, if I were to prescribe this broad-spectrum antibiotic, it may lead to severe diarrhea. Give expectations and an action plan. If you give delayed or if you use delayed prescribing, you can say, your cough may persist, and if you get any worse, we can reevaluate. Or, if I give you this prescription and the symptoms persist, you can then fill the prescription. Within antimicrobial stewardship, it also involves surveillance of currently used antimicrobials. This is especially important within a community healthcare practice. How do we use surveillance within community healthcare practices? First of all, we have to look at why we should measure. What should we measure? And it's always important to remember, if you don't measure it, you cannot treasure it. When you measure antimicrobial use, it is important to consider structural measures, process measures, and outcome measures. And this can then be used to drive action with data within your specific healthcare setting. Why do we measure? We measure antimicrobial use to assess the effectiveness of any of these implemented strategies to determine the effect that they achieved. In other words, have what we implemented made any effect? And we also use it to measure safety data, adverse consequences. This can be implemented within your practice to see if any of the interventions that you've implemented had any significant changes. This can then also be used as a strategy for managerial outcomes to prove your worth to executives and to other prescribers and clinicians and patients. What do we measure? Hospitals and practices alike are struggling to identify appropriate measures of success. The relevant methods and measures for different hospitals or practices will vary depending on the type of healthcare delivered. Access to meaningful data, although a challenge, remains a necessity. Evaluate your data to ascertain if your data set is unstructured? Is there a lack of interoperability? In other words, does the different data sets talk to one another? Do you have set definitions within your data sets? And be aware of administrative data. Administrative data was used for administrative purposes, not to measure antimicrobial use or the success of antimicrobial stewardship. Electronic healthcare records, although useful, are not necessarily a solution to measure antimicrobial stewardship. If there's rubbish in, there will be rubbish out. What are the types of measures that you can use to monitor any intervention that you are implementing within your practice? First of all, evaluate your structure. What is the context in which you are delivering healthcare? Your organizational structure and the available resources that you have available. This includes people and other tools. Which process and similarly, which intervention have you chosen to implement within your practice? Are you going to measure the quantity of antibiotics used, or are you going to measure the quality of prescribing and dispensing? Quality indicators within healthcare setting is freely available and can be very useful in both prescribing, dispensing, and using antimicrobials. And then the outcome. The outcome is the consequence of the healthcare provided, or in this instance, the outcome of the stewardship measure. Outcome measures that may be used include morbidity and mortality outcome of either prescribing and dispensing antimicrobials or not dispensing antimicrobials, and thereby ensuring patient safety. Quality indicators were used in this point prevalence survey that was conducted throughout South Africa to evaluate antimicrobial use, whilst also contextualizing it within a quality indicator context. In other words, what was prescribed, how much of it was prescribed, and was what was prescribed really rational and needed? This is important within the context of antimicrobial stewardship. What were the findings? Interestingly enough, the broad-spectrum beta-lactams still remained the mostly prescribed and dispensed antibiotics. But another finding also included fluconazole use. High levels of fluconazole use were seen throughout South Africa in community and hospital practices alike. Antimicrobial stewardship also involves prescribing antibiotics only when they are truly needed, and when prescribing and dispensing, making sure that they are being dispensed and prescribed appropriately. How do we know when to prescribe and dispense antibiotics when it's truly needed? A concept has emerged in 2018 that is labeled diagnostic stewardship. Diagnostic stewardship involves using the correct diagnostic tools when a patient presents upon clinical evaluation. This involves using the right test for the right patient at the right time. With rapid diagnostic tests, this makes it easier for any practitioner that has to decide on prescribing and dispensing antibiotics. Rapid diagnostic tests can then inform antimicrobial stewardship to allow right interpretation, right antimicrobial, and at the right time, then leading to optimal use of antibiotics for the patient and healthcare at large. What are some of the principles or the key diagnostic stewardship considerations for the implementation of rapid molecular tests? It should be the right test. In other words, your key question here would be, is this test appropriate for my clinical setting? Is it sensitive enough? Is it specific enough? And will it give me the right diagnostic yield? Is it the right patient? Will the clinical care of the patient be affected by the test result? What will be the clinical impact? And is it done at the right time? Will the results be available in time to influence patient care? Time to specimen receipt in your practice? Will you get the results in time to make the right decision? Furthermore, the right interpretation? Will the clinician or healthcare practitioner understand the test result? Do they speak the right language to interpret the test result? Will they be able to then now write the correct prescription for the appropriate antimicrobial? Will the clinician appropriately modify antimicrobials, de-escalate based on the test result, using perhaps clinical practice guidelines where appropriate, and then at the right time? Will the healthcare professional act upon the test result promptly? These are all questions that you can ask yourself within your practice when you practice antimicrobial stewardship, incorporating diagnostic stewardship. Furthermore, if we now have the right antibiotic and we have used the right tests, how can we make sure that we optimize dosing for a patient? Pharmacokinetics and pharmacodynamics within antimicrobial stewardship plays a vital key, as each and every system within a patient's body affects the overall physiology. We have to consider patient-specific factors. For example, does the patient have hepatic dysfunction? How will the antibiotic be metabolized? Is there respiratory failure? Will the patient be able to excrete the drugs appropriately? Are there any renal dysfunction? Cardiovascular dysfunction that may lead to increased volumes of distribution, where you have a hydrophilic compound. Many of the beta-lactam antibiotics are hydrophilic molecules, and if you have a patient in front of you with congestive cardiac failure, their volume of distribution may be altered in such a way that the dose may need adjustment. All of these factors are increasingly important when we decide on the right antibiotics. What are the trends when we look at improved dosing for antimicrobial? Principal trends for improved dosing comes from in vitro and animal in vivo data to define these PK-PD relationships. Then, from these modeling data and simulation papers, describes the optimal dosing that best achieves these indices. Understanding altered pharmacokinetics is key. And then furthermore, knowledge of bacterial susceptibility is vital. Thus, antimicrobial use, prescriptions and dispensing is a specialized field and requires our full attention when a patient is sitting in front of us. Thus, in conclusion, antimicrobial resistance is a leading cause of death globally, especially in sub-Saharan Africa, with the highest burden in low resource settings. There are strategies that we can practically implement even in resource-constrained settings. Working as a team can contribute to combat the growing threat of antimicrobial resistance. And today, within your practice, is a very good day to start. Thank you.